Good morning, everybody. This is part 2 of ARDS. So this is the outline for part 2. We're going to be talking about special ventilatory modes, specifically high frequency oscillatory ventilation and APRV. We're going to be talking about recruitment maneuvers and other therapies, specifically prone ventilation, neuromuscular blockade, ECMO, fluid management, nitric oxide, glucocorticoids, and briefly in the end, some therapies that have been tried and failed. Again, feel free to stop me at any point if you have questions or if something is not clear. The oscillator. It's frequently used in kids with ARDS or premature infants, or neonates rather. It's been tried in the past with limited data, and more recently, which is now not recent anymore, 8 years ago, 2 studies came out simultaneously in the New England Journal. This was the bottom line of the first study and showed no difference between conventional ventilation and high frequency oscillatory ventilation and probability of survival. And the other study showed harm, where it was associated with worse outcomes. So since then, it has fallen out of favor, and people no longer talk much about it in adults. Now I jumped directly into the bottom line, but to go back a step, actually one more thing. In a subgroup analysis of multiple trials, if you look at correlation between outcome and severity of disease, there seems to be a signal towards benefit in more severe disease as expressed by severity of hypoxemia. So this is PF ratio on the x-axis, and this is odds ratio of survival, or more. It's benefit to the left, so this is mortality rather than survival. It seems that when the PF ratio drops to really somewhere between around 60 or so, or below that, which is really severe disease, there seems to be some benefit, whereas when it's above 100, there seems to be some harm. That's subgroup analysis with all the limitations of that. So maybe this is true. It would need to be validated prospectively.
And this is compared to
low tidal volume ventilation. Yes. Yeah. So this is where I want to take a step back and ask a more fundamental question. With high frequency ventilation, normally a tidal volume in a healthy individual, let alone in a patient with ARDS with more dead space, the tidal volume we're talking about a very small tidal volume and very high frequency. We're talking about hertz. That's how it's measured. So it's several breaths per second. And it just oscillates. That's why it's called an oscillator. And you need a special ventilator to deliver it. It's not it's not a standard ventilator. It is an oscillating ventilator. How does it even work? How do you get any ventilation when you're ventilating at a tidal volume that is smaller than the dead space? So the answer is it's not your standard forces that we often think about with ventilation, with your air going in the alveoli by bulk flow, so that you get a little bit of bulk flow into the proximal alveoli, but that's the minority of it. There are other forces, namely something called convection, and there is something called penduloft, which is a process that has been described aside from oscillation, which is collateral ventilation from one alveolar unit to the other. And this happens regardless of whether you're using this oscillation or not, but it plays a role in the setting of oscillation. There is turbulent flow that occurs when you are just, you're shaking the system. So just by this shaking, you are causing, you're basically causing air within the airways and the alveolar units to move around very quickly. It is not ventilation in the classic sense that we often think of with bulk flow. So even though the volume you're delivering with each breath is smaller than that space, there is enough flow that occurs sufficient to clear out some CO2. But the macroscopic way in which we think of CO2 clearance, where you would expect that increasing tidal volume will drop your PCO2 by a certain amount, doesn't apply anymore because the forces, the mechanical forces responsible for the clearance are different. APRV. This is the only slide I have about APRV. And even though it is now more widely used than it used to be, and the reason this is the only slide I have is this is really the best data we have for it, which as you can see, is a small study. It's not the only study, but this is the largest study that was done. And it's 71 patients in the APRV arm. And this is conventional ventilation. 67 patients, and it did show improvement in outcome. The outcome here was percentage of patients breathing without assistance. And this is days since randomization. So it's not mortality, but this is an important outcome, which is how soon you can get them off the ventilator. What APRV stands for is airway pressure release ventilation. And the way it works is you give a very high CPAP, or it's similar to PEEP, except it's not really expiratory anymore. It's sort of, you set a high baseline pressure, and then every so often, not frequently, in this instance, it's about every 7 seconds or so, you release that pressure for a brief amount of time. These releases will result in a breath, just because when you release the pressure, that results in an exhalation, and then you build it up again. So that results in some ventilation that way. The patient is not paralyzed, they're not deeply sedated, so they're still breathing spontaneously on top of that. So they get their ventilation in two ways, by these pressure releases and by their spontaneous breaths. The idea behind it is that because you're giving them such a high pressure at baseline, you are recruiting a lot of alveolar units. So their oxygenation is preserved. And you rely on these two mechanisms for ventilation, so you're clear enough CO2, but your focus, as is often the case with the ARDS, is on oxygenation. So it's a mode that focuses on recruiting as much as possible. And because you're not doing frequent inflation-deflation, you're trying to protect the lung from injury. So you're using high PEEP. It's not necessarily PEEP in this case. It's really, in a way, it's an inspiratory pressure rather than expiratory pressure. CPAP is what they're calling it here, which I think is apt. It's positive airway pressure. It first gained popularity. It's existed for a long time. It gained popularity about during the H1N1 pandemic, which was in 2009 or so, because we had suddenly a large number of cases of severe ARDS that were difficult to ventilate. And that's when we started seeing some more data about it. And it works. I mean, it's one option to ventilate these patients. So I don't have anything against it. It's just that there is paucity of evidence that it's better than conventional ventilation with low tidal volumes and appropriate use of PEEP. The one point that goes against it is it requires familiarity with the mode. So if you're familiar with it, your respiratory therapist is familiar with it, and you have a ventilator, not all ventilators have APRV built in as a mode. There's a workaround that you can use to apply something similar to APRV. But it can be a little bit confusing and how then to troubleshoot it and titrate it. So if you're familiar with it, you know how to apply it, you have RT on board and they're buying into it, it's perfectly fine. It's not harmful. There is potential benefit based on this study. Take it with a grain of salt because of the small number of patients. But there's no signal towards harm. There's signal towards benefit. It's perfectly fine.
Does this require a spontaneously breathing patient?
It does, because these release points are not going to be sufficient to provide you enough ventilation on their own.
So they'll be spontaneously breathing on top of the continuous airway pressure.
Correct. I mean, theoretically, you could apply it to a patient who's not spontaneously breathing and then increase those pressure releases. But that sort of defeats the purpose, because then you are doing frequent releases and frequent deflations. The idea of this is that you want to maintain this inflation pressure for as long as possible. And if you have to release the pressure too frequently, then it's not achieving what it's supposed to do, which is maintain the recruitment for extended periods of time. If you have to increase these, what they're calling release phase, in order to achieve some degree of ventilation, then you're not achieving what it's intended to do in the first place. This leads us to speaking of recruitment. So recruitment, the idea of recruitment is that because ARDS has this heterogeneous pathology where some areas of the lung are more affected than others, and this is a dynamic process, meaning it can change if you reposition the patient, because a lot of it is pulmonary edema. Trying to re-inflate some alveolar units that are deflated will improve oxygenation. And the way people have done this is by having periods where you use, brief periods where you use higher pressures or higher tidal volumes. And there's not just a single way of doing recruitment, this is, I just pasted here, an official statement, or a statement from the official ATS, ARS guideline on ARDS, and it says, we suggest that adult patients with ARDS receive recruitment maneuvers. It's a conditional recommendation with a low to moderate confidence, but it doesn't prescribe how to do recruitment. Now, this was a study that came out that did recruitment, and what they called a titrated PEEP versus low PEEP, and they looked at mortality as their outcome. It came out in JAMA in 2017. So this was their recruitment maneuver. And if you look at the airway pressure that they use, so the way they did their recruitment is by gradually increasing their peak airway pressure and their PEEP, maintaining a driving pressure of 15 until they got to a peak airway pressure of 50, which is very high. And then they dropped it back to baseline and gradually dropped it. This is time in minutes. So they did that. Each interval here was 1 minute long, and then over 3 minutes, they maintained this pressure, and then each of these was for 3 minutes. So the whole thing lasted for 18 minutes. And then they did another new recruitment briefly, and then they went back to maintenance ventilation. The results were not great. So they had actually increased mortality with this maneuver. They had a few cases of cardiac arrest during the maneuver. And one could argue that this is not because they did a recruitment maneuver in principle, but because that recruitment maneuver was very aggressive and they used very high pressure. And this may well be the case. Like if you use pressures this high, you're going to impair hemodynamics, and you should be, and if you prescribe a protocol that's aggressive and you try to adhere to it and you're not paying attention to everything else, you're gonna run into trouble. You should be more mindful when you're doing recruitment. And this may well be true. That being said, there is no evidence. So, I mean, this recommendation here says low to moderate, conditional recommendation, low, moderate confidence and effect estimate. There is really no robust data showing that recruitment maneuvers improve outcome. They do improve oxygenation. You see it like directly. You do a recruitment maneuver, oxygenation improves, and the improvement, once you're done with the maneuver, the oxygenation is good, and then it gradually declines. That's just a direct effect. Recruitment in itself does recruit alveoli, and that directly your oxygenation is going to improve. But improvement in oxygenation does not correlate with improvement in mortality or with weaning from ventilation. This is clear from multiple trials in general. Like the largest trial that showed improvement in mortality was the low tidal volume ventilation, and that group had worse oxygenation and yet had better survival. So oxygenation and survival do not correlate. So my take on this is, well, my bias is I don't believe in recruitment maneuvers, to be honest with you. But if you do want to use recruitment maneuvers, you need to be careful and not go crazy like these pressures that they used here. These were excessive, and clearly they had worsening mortality with it. Now, obviously, as this applies to everything, patient selection is key. So maybe recruitment maneuvers are beneficial in a certain subset of patients, but harmful in others. And how do you select your patients? But I mean, this applies to everything. So I cannot make an informed suggestion in that regard. Non-invasive ventilation. So the issue with non-invasive ventilation is ARDS is not a rapidly reversible illness. The course of an illness takes many days to resolve. So non-invasive ventilation is generally not a good idea. If unlike a COPD exacerbation or a heart failure exacerbation, where you would expect a day or two things to settle down and maybe you can get by and avoid an intubation, if you know you're dealing with ARDS, which a lot of the time you don't know from day one, and hypoxia is worse, is bad enough to require mechanical ventilatory support, invasive ventilation is the way to go. So this is a study that compared invasive versus non-invasive ventilation, and for their entire sample, there was no difference in outcome. If you divide it by severity again, people with more severe hypoxia had worse outcome with non-invasive ventilation. That's the gray line here. And if you look at people with with less severe disease, there was no difference. Overall, the entire sample had no statistical significant difference, but the trend was towards worse outcome with non-invasive ventilation. So generally speaking, if you're dealing with ARDS, you're better off intubating them early on. Now, again, because ARDS is a syndrome and not a diagnosis, a lot of the time you don't know what you're dealing with early on. And for somebody who's just getting hypoxic and you're trying to figure out what's going on, it's fine to put it on while you're, as a support for their hypoxia, while you are getting your X-ray and cultures, etc. But once you know what you're dealing with, this is a septic patient with new infiltrate and severely hypoxic, they're going to need to be intubated. And a lot of the time, the situation dictates itself. They're too unstable for non-invasive ventilation. They're not alert enough. They're too hypotensive, etc. All right, moving on to things besides mechanical ventilation. Prone positioning. So prone positioning is the one intervention besides low tidal volume ventilation that actually does have data supporting like good randomized control study data showing improved mortality or improved survival. And this is from the study from 2013 showing that selected patients with a PF ratio of less than 150. And they were placed in a prone position for at least 16 consecutive hours per day. So there were preceding data to this study that showed that proning improves oxygenation, but not survival. However, the studies prior to this did not prone people for that long. So this study adopted an aggressive approach. This is along like most of the day, 16 hours per day. And they selected people with more severe disease, PF of less than 150. And now, two things to note here. One is the survival difference was very big, almost too good to be true. Is it too good to be true? I don't know. I mean, this is what the results show. And were they just lucky that they got this that one time? It hasn't, like, nobody has tried to replicate it since, so I don't know. But it was a well-conducted randomized controlled trial, and this was the result. And I think until we have data showing something different, we should be proning patients who meet these criteria. This was a study that was done in Europe, so their patients were generally much more lean than our patients. They were easier to prone on average. They did not use a special bed to prone them, they just turned them around. Special beds do exist to prone people. I know at the VA a few years ago, after the study came out and we started getting the protocol to prone people, the company that rents these beds out came and did a demonstration, and the nurses hated that bed. They found it to be too cumbersome, and they prefer to just prone the patients manually. It takes several people to do, and you need not only the patients are heavy and you need several people to roll them, but the most important thing is you want to make sure that their ET tube doesn't come out, their central line and Foley catheter and all of these things don't get dislodged in the process. Because proning someone is cumbersome, you really need buy-in from your staff that, yes, this is important, we need to do it. We haven't had any problem with that. Like if you tell the nurses we need to prone somebody, we haven't faced any resistance. Where we've had resistance is the threshold from our end to decide to prone somebody has been high. So I can tell you, we do not prone everybody or most people who meet these criteria. Because we're like, oh, let's try something else first. And it's like, it's not either or. You can prone them and do the other things that you want to do. There are like limited, some side effects. You get some skin breakdown in their face, etc. There are mitigating things that you can do to address that. But I think we should be proning more people than we currently are. They do, sometimes favorably and sometimes unfavorably.
And feeding is okay, right? That's what
Yes, feeding is okay. And now, why does proning work? There is actually, now the original hypothesis of why we should prune people is simple. Two main things. One, because pulmonary edema, the edema part of ARDS is going to shift when you prune people. So immediately, your perfusion is going to improve to areas of the lung that are dependent, that used to be dependent and meaning towards the back, you get the worst pulmonary edema, but that's also the area that is getting the best perfusion. So you have bad VQ matching. Because the area that is getting the best perfusion is the area that is getting the worst ventilation. As soon as you flip them, perfusion immediately is going to improve towards the front of the chest, and that area gets better ventilation because it is less affected by pulmonary edema. It's going to take hours for the pulmonary edema to shift to the front. So that's how your VQ matching improves immediately. The second part is the weight of the heart compresses the left lung specifically, and you get rid of that when you prune somebody. Now, these were the things that were originally led to the hypothesis of pruning. There are additional factors that are more complex, and honestly, I don't know them off the top of my head, but there's a good article in the Blue Journal from maybe 2015 that described these benefits in more detail. All right. Neuromuscular blockade, true or false? Routine use of neuromuscular blockade decreases mortality in ARDS. What do you think? Just give some.
I don't think it's improved the mortality.
Okay, so you say false. What do you say?
I say false.
Okay, they overruled you. I appreciate your courage, though. All right, so you're not wrong, you're just outdated. This was the Accurasis trial that looked at that question specifically. Cisatracurium versus placebo, so 340 patients, 48 hours of ARDS, PF ratio less than 150, and they did 48 hour neuromuscular blockade for 48 hours. So they didn't look for patients with dysynchrony. They didn't wait for them to be fighting the vent. They just decided we're just going to give them all neuromuscular blockade. But because in order to do neuromuscular blockade, you have to do deep sedation. The way they did it is they gave deep sedation to both groups. And because proning was, these patients actually met criteria for proning, they did prone a significant number of them, which is good for them. And what they found is they did improve survival in the neuromuscular blockade group. This was back in 2010. Now, this was done, I know this was published before the proning trial, but they were being done around the same time. These trials take years to conduct and to get the results all published. And it was done in Europe as well. I think France primarily. More recently, the ROSE trial came out. It was bigger, multi-center, multi-country, and 3 times as big, so 1,000 patients. Same PF ratio less than 150, neuromuscular blockade for 48 hours. But one important difference is that the placebo group did not get deep sedation because they didn't need it, so they just gave them light sedation, which I think is more reasonable. But they didn't prone many people, only about 16%, which I think is not great, but more representative of a real world experience. And they didn't really find any difference between the two groups. And this is survival on top and hospital discharge, and the curves are almost superimposed. And looking at why the two results are different. So these are some differences between the two trials. I said the ROSE was multi-country. It actually wasn't, so it was in the United States, but 48 hospitals. So the ROSE trial was bigger. Maybe it was just Accurasis wasn't generalizable when you try to expand it to a bigger sample. This was double blind, which was the reason for giving deeper sedation to the unparalyzed sample. This was unblinded because if you're giving light sedation and no paralysis, you're gonna know, like you can't blind that. Same level of severity, median time from ARDS diagnosis, this is in hours, so not really that difference, 8 versus 16 hours. We talked about sedation, and we talked about the fact that they prone some people here, they didn't prone some people here. Or they prone many people in the Cursus trial, very few in the Rose trial. So maybe you realize the benefit of neuromuscular blockade if you prone patients. It's possible. Or maybe this benefit wasn't real, and once you get a bigger sample size, you lose it. Maybe the benefit, maybe there was some harm from deep sedation in that group that wasn't paralyzed. Like there was some benefit from paralysis, but there was also harm from deep sedation without paralysis. And then once you took out the deep sedation, the benefit wasn't that great. So there's several potential explanations, and in reality, we don't know. What we know is if you're not chronic people, like we're not for the most part, and you're not giving them deep sedation, which we don't, just giving them paralysis is not gonna help. ECMO. So there are two large, by ECMO criteria large, they're not that large, studies about ECMO. The older one is the Caesar trial. They're both done in Europe, the two studies about ECMO. The Caesar trial randomized people to ECMO, and they were transferred to an ECMO center if they met criteria. And they looked at survival at 6 months, and they saw a survival benefit. These were people with severe ARDS, but not the way we often think of ECMO as salvage therapy when everything else was failed. They were more proactive. Like you don't wait for multiple organ failure. That's actually a relative, like that's when you don't do ECMO. More recently, and a more robust study was the Eolia trial, also done in Europe. Very severe ARDS as indicated by one of 3 criteria. So PF ratio of less than 50, PF ratio of less than 80, so less than 50 for 3 hours or less than 80 for 6 hours, or pH of less than 7.25 with a CO2 of more than 60 for more than 6 hours. And again, they saw a signal towards benefit. It did not quite meet statistical significance. But the one thing to point out here is they allowed crossover from the control group to the ECMO group. So there were a few patients that did crossover because they were deemed too severe by their treating physicians, and they requested ECMO. And because it was an intention to treat analysis, they were counted in the control group. If you do as treated analysis, the ECMOs would be beneficial, would have been found beneficial with statistical significance. So there is a signal that ECMO is beneficial if used in that way, keeping in mind that the way it is done in Europe is a little different. It's not every hospital has an ECMO machine and they do a few cases per year, but rather they have it's more centralized. So there are a few centers and they do many cases. So they gain a lot of expertise in doing it. And this is important because it's a highly specialized procedure. And if you do more of them, you're more likely to have better outcomes, at least theoretically, if that makes sense. All right, in the last few minutes, Fluid management, conservative versus liberal strategy, meaning do you keep them dry or do you keep them wet? So this was a study done, this was the FACT trial. It looked at two different things. One of them was the fluid approach, and they had a pulmonary arterial catheter. Their goal was either a wedge pressure of 8 or 14 to 18. That's conservative versus liberal. If they had a CVP, their goal was 4 versus 10 to 14. And there was no difference in mortality, but there was earlier weaning of the vent in the conservative strategy. So generally, they came out of this recommending a conservative fluid strategy once they're out of their shock. Meaning the protocol was you treat their shock initially if they're in septic shock, which many of these people were, you give them fluid as needed, etc. But once they haven't required any pressors or fluid boluses for 12 hours, if their CVP was greater than 4 or their wedge was greater than 8, you try to diurese them. But there was a subgroup, a retrospective analysis later on, not retrospective, but a subgroup analysis later on, a follow-up to this study that showed that people, it's only a small number of patients who they were able to follow up on. It showed that people in the conservative fluid strategy had more neurocognitive impairment later on. Now, it was a small number of patients, and this was done independently. After the fact, they decided to follow up on these people, and they only could get hold of a small number of them. And what they found was maybe it's associated with more neurocognitive dysfunction. Makes me a little bit concerned, but I don't know if it's, I don't know if it's enough of the size of the sample is so small that I don't know that you can draw much conclusions from it. Albumin and Lasix. This is a very small study just because I put it in there because the situation often comes up and people ask questions about it all the time. Trying to diuresis somebody, they're hypoalbuminemic, they have a lot of edema. Should we give them albumin and Lasix? And the answer is, when you do it in the short term, it improves their blood pressure. This is MAP, and this is the albumin and Lasix group. It improves their blood pressure. It improves their oxygenation briefly, just for the first 48 hours. The effect is not lasting. It does not get them liberated from the ventilator sooner. So it makes you feel better. It has short-term benefit. It's not lasting. This was the second part of the FACT trial looking at, do they need a pulmonary arterial catheter or not? The answer is no. Nitric oxide. Nitric oxide, as you all know, improves oxygenation. And the way it does that is by improving VQ matching. So because it is inhaled, it goes to alveolar units that are well ventilated. So it selectively dilates blood vessels in areas of the lung that are ventilated. And therefore, it improves perfusion to areas that are well ventilated, thereby it improves VQ matching. It improves oxygenation. It does not improve other clinical outcomes, but using it as a salvage therapy, as a bridge until you buy you some time to get something else to work, in selected cases is probably reasonable. Because it's so expensive, a lot of the time it's in place, people are using prostacyclin, which works in a similar way. It's also a pulmonary vasodilator. It's sort of an off-label use. The same intravenous prostacyclin that is used for pulmonary hypertension is nebulized and given in an inhaled form. It is, even though that one is expensive too, it's actually much cheaper than nitric oxide. So these are, nitric oxide has been tested since 1998, and Most trials look at oxygenation. Results are mixed. It does improve oxygenation. You can see it, but the effect is not lasting. Which of the following has negative clinical trials in ARDS? Surfactant replacement, neutrophil elastase inhibition, anticoagulation, NSAIDs, statins. All of them. Good job. Okay, last thing, glucocorticoids. So there were older studies in ARDS, and what I wanted to point out, that were negative, but what I wanted to point out is that they used ridiculously high doses of steroids. So methylprednisolone, 30 milligrams per kg for 24 hours. 30 milligrams per kg, if we're talking about a 100 kilogram patient, we're talking about 3 grams. Short burst, but it's like huge dose. Brief, but like this is bigger than the pulse dose that you would use to treat a flare of lupus or something along these lines. More recently, this is dexamethasone, 20 milligram daily, which is a high dose still, because this is dexamethasone. For 5 days, followed by 10 milligrams for another 5 days. It was not a blinded study, and it excluded, as you would, it would exclude patients who are already getting steroids. Sorry about that. And it did show actually a survival benefit. So dexamethasone in this study showed improvement in outcome. Now, in late ARDS, defined as more than 14 days since the onset, steroids have not been shown to improve outcome. They've actually been shown to worsen outcomes. So number of ventilator-free days at day 28. Now, two things here. This is in everybody, not just early. This is a mixed population, not just late ARDS. So ventilator-free days in general were improved in this study that used methylprednisolone. But if you look at mortality data for people who had more than 14 days since their onset of ARDS, mortality in prednisone was higher than that in placebo. That's 60-day mortality. This is a systematic review of multiple corticosteroid data, and this is on the left, it favors glucocorticoids, on the right, it favors control, and overall, it does favor corticosteroids. This is a subgroup of randomized at day 14 or later, and it favors control. So in general, this is SCCM guidelines, suggest use of corticosteroids in patients with early, moderate to severe ARDS, defined as PF ratio of less than 200, within 14 days of onset. It's a conditional recommendation, moderate quality of evidence. And this is a suggested treatment protocol. Now, you can think of this, I mean, more recently we've been using steroids for COVID, and we've been using dexamethasone, which is fine. This is a little bit, it's different. That's COVID, this is ARDS, and that's COVID, whether or not they have ARDS, but I think it's somewhat similar. Steroids have been around for a very long time. They've been controversial. I think they're always going to be controversial. There's going to be some more negative data that's going to come out, and then some more positive data. That's my prediction. But I think as of now, the data really seems to favor them. They don't seem to have as much traction as they should. Maybe because people are wary, because it's gone back and forth, but I think we should be using them until we learn otherwise. I think we should be wary of very high doses, but unless there's a contraindication, we should really be thinking of them more often. Failed therapies. So the things that I mentioned already are some of the things that you probably have never heard of anyway, so it doesn't matter. So final thoughts, remember low tidal volume, prone position, consider ECMO, consider high PEEP and severe ARDS with caveats. Be careful with recruitment maneuver. Consider steroids, but really low tidal volumes. I would point out that an editorial came out by Dr. Martin Tobin, who's one of the authorities on mechanical ventilation, that was titled The Dethroning of 6 cc's per kg. The title is unsettling, but when you really read it, what he's saying is that you should also look at a plateau pressure, and if the plateau pressure is not high, maybe you don't need 6 cc's per kg. So he's not saying don't use low tidal volumes, but it's still unsettling. Any questions?
Thank you, Dr. Shatat. Can I ask a question about the non-invasive?
Yes, go ahead, Martin.
So, you know, initially with COVID, it was like, you know, intubate the patients early and all that. And then we found out that, you know, we had, you know, patients did worse when we intubated them early. And we've had COVID patients on non-invasive for days, essentially, and never end up intubated. So as far as other ARDS pictures, it's still, if it is ARDS, you're saying we should be intubating and not trying non-invasive?
That is correct. So two things about that. One is you're right, and this may be part of the argument, which I think is largely true, that patients with COVID do not have, at least a large subset of them, do not have what we classically think of as ARDS. They have viral pneumonia, they have the bilateral infiltrate, even though they meet the criteria for ARDS because our definition is crude. They do not have the decreased lung compliance. So they don't have the same pathology that we think of as ARDS. That's one thing. The other thing is most of these patients are not on non-invasive ventilation, but rather on high flow, which isn't non-invasive ventilation. That's just high oxygen. The study that I showed was specifically non-invasive ventilation, meaning they're on like either BiPAP or something along these lines. Is that correct? Or are you thinking of patients who are actually on mechanical ventilation non-invasively?
You know, I think you're right. I do think that the phenotype is totally different when they're, you know, their compliance is fine in a lot of these COVID patients. Yeah, they're most of them on Airvo, but there are some patients that I've seen on, you know, BiPAP or for a couple, at least a few days. But yeah, I'd say the phenotype is largely different.
I know this is also controversial because an opinion article came out suggesting phenotype H, and I forgot what the other one of COVID, which I think had some truth to it. It was just, there was something gimmicky about it. Like, why are we coming up with these nomenclature when we don't really know what's going on? But the truth is that, yes, clearly some of these patients, when you look at their respiratory mechanics, do not have classic ARDS picture.
Correct, yeah. Okay, thank you.
Sure. Any other questions? All right, thank you.